Hello and welcome to another edition of the Osteopathic Lyceum podcast. Today, what we're going to do is go over the concept or concepts of pathology and pathophysiology, specifically with respect to hands-on osteopathic practice. So, when I make when I go through this discussion, understand that I'm not specifically speaking to the American doctor of osteopathy. I'm speaking more so worldwide to those hands-on practitioners within the field of osteopathic manual therapy. Now, that said, I have to acknowledge first that jurisdictions are different. Each jurisdiction is going to have different things that the practitioners are allowed to and not allowed to do. There will be some jurisdictions in the world where an osteopathic practitioner is appropriately regulated, and they are provided with the opportunity to develop specific diagnoses or diagnoses within a very, very constrained range. Now, that said, the fundamental essence of osteopathic hands-on practice probably doesn't lend itself well to doing that. It doesn't mean that these people are incapable of it. It's just that the nature of hands-on osteopathic practice and the environment of observation that we have is entirely external and entirely based on essentially assessment without tools. Some osteopathic manual practitioners will be trained to use things such as otoscopes and stethoscopes. Many will not be. So the reason I go back to that more macro position or that more pulled back default position of assessment without tools is because you will find that everywhere. You will only find assessment with tools such as otoscopes and stethoscopes in a small amount of places around the world. So the fundamental feature of osteopathic diagnostic procedures within the hands-on osteopathy realm is just that. It's that external observation of the patient. So you will get information from them. They will provide you with report, and you will have motion assessment, and you will also have, to some degree, assessment of tenderness, which can relate to particular conditions. But it's not a fundamental feature of the profession, right? If hopefully that ends up making enough sense, such that you can draw a distinction between the type of assessment that a hands-on practitioner, an osteopathic manual practitioner, is able to do versus an osteopathic physician or a physician generally speaking. There are many more diagnostic avenues open to physicians, either if you want to say allopathic physicians, just physicians, or osteopathic physicians, such as doctors of osteopathy in America. So again, the fundamental feature is an external environment of observation and no tools for diagnostics. So we can acknowledge to some degree that that position does not allow as much insight as a position that allows diagnostics with images, with tools, with blood assays, right? So that is not available. Now, that said, what we're going to do is be as clear as we can with terms so that we are able to have an appropriate discussion here. Right now, I'm going to bring up my screen. There we go. I'm going to adjust the size of my speaking window here, so please give me a moment if you're only listening. This isn't as meaningful to you, but if you're watching, you're seeing this happen. So what I'm going to do first is and actually before I do that, I'm going to do something else. I'm just going to do that. There we go. That should more or less do the trick. So please excuse me for the rambling. So first we're going to define pathology, pathophysiology, and physiology so that the discussion ends up having some meaning, right? So, and we're looking at common enough or accepted definitions. Now, you can have some disagreement with specifics of the definitions, but I think for the terms of the discussion, they're broad enough that they'll do the job. So, pathology, defined as the study of the essential nature of diseases and especially the structural and functional changes produced by them. Now, if you're going to contrast this, then what you can say is or you can maybe pull this back and say it's just the identification of a condition or a disease, like the identification in and of itself, not necessarily any further description. It's just the steps you would take to name or identify a condition or a disease, not necessarily the process, but the disease, right? So then we go over to pathophysiology so that we have something to contrast against. Pathophysiology is the physiology of abnormal states, or specifically the functional changes that accompany a particular syndrome or disease. So essentially, if you were to look at how this would play out, subsequent to the identification of the disease, you would then consider the functional changes that accompany that disease. And when you say functional changes, usually you're talking about the cellular level. So you'd be speaking about things in the blood, specific cells present in the blood, specific cells present within the piece of anatomy that you're looking at. You're looking more at that cellular level. Whereas pathology, in contrast, would maybe be a little bit more gross, right? So it would be the actual anatomy, what has occurred to the anatomy. So you can name it based on a change to anatomy. Nothing is immediately coming to my head. Let's just say an abdominal aortic aneurysm, right? That's the identification of it because there's a physical description. You have an aneurysm, which is an outpouching of the abdominal aorta specifically. You could have a thoracic aortic aneurysm, right? So you get that identification on more of a physical level. Now, physiology is still physical. However, it's a smaller component. So it's not necessarily gross anatomy at that point. It's cellular anatomy as a distinctive or a distinguishable characteristic. So then we move over to physiology specifically. So we just do this to kind of push more information into this discussion. So physiology is a branch of biology that deals with the functions and activities of life or of living matter, such as organs, tissues, or cells, and of the physical and chemical phenomena involved. Right, so that's why now it's including organs, tissues, or cells. What I would say is that as a distinguishing line, you can say that the gross anatomy would be anatomy of the larger structure, naming the whole thing, versus the physiology would be the subcomponents. So you talk about specific cells in the pancreas, right? So the islets of Langerhorn or things of that nature. If you're talking about the endocrine versus exocrine functions of the pancreas, you're talking about physiology. If you're talking about the pancreas, you're talking about anatomy more so, right? And then if we're going to talk about, so you could say pancreatitis as a pathology, then the pathophysiology would talk about the specific functional changes more on the cellular level. So you're getting into smaller components. So hopefully that helps with the understanding of a base delineation or distinguish between the ability to distinguish between pathology and pathophysiology. Pathology is identification, and it's a little bit more gross or a little bit larger in its scale. Pathophysiology is essentially the functional changes that can be distinguished on a smaller level, and we can say cellular, right? Please excuse me for kicking my camera. Now, the next thing that we're going to do is take some consideration of the level at which an osteopathic manual practitioner is able to deal with the amount of information that would be required in the study of pathophysiology. Now, because, as I noted, the essential feature of osteopathic hands-on practice is that the diagnostic ability or the assessment ability is from an external environment of observation with no tools. So you're checking compliance of tissue, so yield to pressure of soft tissue. So you push into a soft tissue and it either yields or it doesn't. You're also considering gross motion, right? And then you're considering the report of the patient. So you can get very, very rough ideas of where something might be going on, what might be going on, deeper than that gross external environment or that macro or large external environment. So you can point in a direction, but your ability to actually differentiate and do any form of pathophysiology is essentially nil. You do not have the ability to do pathophysiology. You really don't, in a meaningful way, as manual hands-on osteopathic practitioner, have the ability to truly do pathology either, because the rules that will govern your practice or the lack of rules that govern your practice do not give you the access to the ability to identify disease processes in almost any way other than to say, this soft tissue is not yielding appropriately to pressure. This gross motion is not working appropriately. Right, so this shoulder is not going all the way up. This neck bends to the left and not to the right. You can say those types of things, but you can't necessarily say that it's a spastic torticollis officially. You may see somebody come in like this and they can't move anywhere else. So you can know through appropriate intake of information that it's very likely a torticollis, but you won't be allowed to say it is. So to make a more useful description, hands-on osteopathic practice is in the general business of identifying very, very gross pathology with almost no naming, right? So you can identify that something is not functioning with respect to movement as it should, but you can do no more. So hopefully that puts us in a decent position. So we understand pathology as the identification of the disease, the pathophysiology as the essentially study of the altered functions in relation to a pathology. So you name a disease and then what the heck is going on at the smaller level with respect to function, that's the pathophysiology. We know that the external environment of observation and the lack of tools is the realm of the osteopathic hands-on practitioner. Therefore, we can identify gross pathology with almost no naming ability. Okay, so if I go to a search term, so you can see the search term here, and it is pathophysiology PubMed textbook. And so if you do that, there's an initial article, the biological principles of disease. You don't need to look at that one for the purposes of what we're doing. You click on what's called statprols-NCBI bookshelf, and you'll come to this, as long as it actually works. There we go. So the National Library of Medicine, National Center for Biotechnology Information. See, StatPearls, it says contents, right? So you will have the editorial board, then 111 Indium white blood cell scan, and so on. What I'm going to do is a very smooth scroll of this, and we'll stop at varying points. So you see how far I'm going if you're actually watching this. We stop, we get to adhesive capsulitis, Addy syndrome, adiposis dolorosa, blah, blah, blah. We'll get into the anatomy section here in a moment. So you've just got a bunch of anatomy resources. These anatomy resources are quite useful because they're collected by multiple authors. They have a lot of information. They're very, very useful. Scroll, 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 still in the anatomy, scroll, scroll, scroll. Now we're into the A's, anti-arrhythmic medications, antibiotic prophylaxis in dental and oral surgery practice, antibiotic resistance as headings that pop up. Scroll, scroll, still in the A's, scroll, scroll. In the B's now, let's stop here. Beta-lactam antibiotics, Bezold abscesses, biceps tendon dislocation and instability, biceps tendon rupture. And when you click on any of these, you'll end up seeing pathologies, right? So I'm just going to keep scanning here until we get to the bottom. Still in the B's, scroll, 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 scroll. We're in the C's now, cardiac stress imaging, cardiac surgery, cardiac tamponade. Scroll, 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 still in the C's. Clear cell renal carcinoma, scroll, 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 scroll. We're in the D's. Let's see, diphtheria, diplopia, scroll, scroll, scroll. Scroll more, we're in the E's. Let's go a little farther. Enucleation, enuresis, eosinophilia, eosinophilic esophagitis, eosinophilic gastroenteritis, right? Lots of names, big fancy names. Scroll, scroll, scroll. We're in the F's, I think. Follicular adenoma, follicular lymphoma, follicular thyroid cancer, folliculitis. Scroll. You're starting to get the idea of just how many things are going to relate to the concept of pathophysiology. So any condition, any named disease will then have some form of pathophysiology. So now we've scrolled a bunch. We're in the eyes. I don't know. Infant head lag, infant apnea, infantile botulism, infantile cortical hypertrosis, right? So hyperostosis, please excuse me. So again, we're going through the eyes, scrolling, 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 just keep scrolling, 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 right? This goes on for a very long time. We've gotten to the M's because I kept going. Mesenteric artery ischemia, mesenteric artery thrombosis, mesenteric vasculitis, right? So these are the identifications in the diseases. This is the pathology. And then when you click on these, you'll get some pathophysiology. scroll, scroll, scroll. Anyways, I don't necessarily need to actually go to the bottom. But if I did, you would understand that this goes on for a very long time. And despite its being large, it's probably not legitimately exhaustive, if that makes sense. Hold on. Just pull this down a little bit so I can get to where I want it to be. I'm going to go into one that I chose before. This is abdominal angina. And I will just correct something here. Pull this up. No, that's okay. All right, I'll pull this up to a point that I can use it. So this is the entry in that StatPearl's essentially pathophysiology resource for abdominal angina. Okay, we'll go to etiology of abdominal angina. The ischemia of the intestine results from an imbalance of oxygen supply to and oxygen consumption by the GI tract. A decrease in blood flow results from a decreased size of mesenteric vessels. Atherosclerotic disease is the most common cause of abdominal angina. It frequently involves ostia of the, I believe an ostia is a blockage of the mesenteric vessels. It's a blockage of some form, but I'm not necessarily sure. There's some other information there. In most people, is occlusion of the superior mesenteric artery that is responsible for the abdominal symptoms. Risk factors for superior mesenteric artery atherosclerosis include smoking and hyperlipidemia. If we go down to the pathophysiology, just to read from this, abdominal angina diminishes blood flow as a result of narrowing of the mesenteric vessels. So that was there in the etiology. The most common cause of abdominal angina is an atherosclerotic vascular disease at the ostia of the mesenteric vessels. Superior mesenteric artery occlusion is usually found in patients with symptomatic occlusive mesenteric ischemia. Shortly after eating, patients with abdominal angina are unable to increase flow in the mesenteric vessels and they develop pain. So from the pathophysiology, what you could predict as an osteopathic practitioner is your patient would report and say, after I eat, I have very notable pain, right? Now, that doesn't mean that you can go to the point where you would be able to identify specifically that it's the superior mesenteric artery with an occlusion and they are not able to increase blood flow to the small intestine subsequent to eating. You're not necessarily going to be able to do that, but the report would be pain after eating. We'll look at the history and physical, right? So the typical presentation of abdominal angina is severe pain out of proportion to the physical exam, right? So when you palpate the abdomen, they don't necessarily show the pain, but maybe I'm mistaken that. I think I'm actually making a mistake there. How hard you press versus how much pain they display. So you press very softly and they have a lot of pain. Patient usually complains of severe abdominal pain that starts after eating a meal, as I noted. In most cases, the pain gradually subsides after a few hours. Because the pain is so severe, most people develop fear of eating and hence lose weight. One should always ask about history of smoking, claudication, hyperlipidemia. On physical exam, marked weight loss is obvious. Abdomen is often soft and there are no peritoneal signs. Abdominal bruit may be heard in some patients. That's something that an osteopathic practitioner is not going to be able to do, right? What I can say for the osteopathic hands-on practitioner without tools is if somebody says they have a lot of pain after eating, you palpate their abdomen for some reason and there's a lot of pain, that's not a sign for you to believe that this is abdominal angina. It's a sign that they need to be sent to somebody who can diagnose appropriately. You would tell them to present this information to a physician, and the physician would take on the case from there. But that then bolsters to some degree the argument that we can identify gross pathology. We can identify when things are not necessarily as they should be. We can identify when further diagnostics are needed, and we can send on for that purpose. So lots of abdominal pain. After eating, you palpate the abdomen, very soft, and they have a lot of pain. It's time to send them on. It's not necessarily time to try to be a superhero because you're probably not necessarily going to be able to safely and intelligently interface with this person up until such a point as further investigation has been done. So you want to send them on for that investigation. Again, further bolstering the claim that we, as hands-on practitioners, are bad at pathophysiology. We're okay at gross pathology with almost no ability to name it, right? Now I go to another one, accessory nerve injury. So the cranial nerve 11, etiology, most common cause for accessory nerve injury is iatrogenic, which means injury in the delivery of healthcare, appropriate healthcare. So as they're doing something, that starts the disease. As an intervention has been being provided, that is the beginning of the disease process. So I'll go back to reading, such as lymph node biopsies that involve the posterior triangle of the neck surgeries, including removal of a tumor, carotid or internal jugular vein surgeries, neck dissection, including radical, selective, and modified, or cosmetic surgery, e.g. facelift from the mechanical stress exerted on the neck due to positioning throughout the procedure. Other causes are penetrating trauma, such as knife or gunshot trauma, blunt trauma from pressure, stress to the neck area from a sudden movement, or acromioclavicular joint dislocation affecting SCM. Other possible sources of injury are neurological, in which the nerve or the foramen it passes through are affected, leading to cranial nerve 11 palsy. Examples are a tumor at the jugular foramen, which causes cranial nerve palsies, such as Collet's-Card syndrome, involving cranial nerves 9, 10, 11, and 12, and Vervet syndrome involving cranial nerves 9, 10, and 11. Okay, so what you can see is that there is trauma during medical procedures that is causing either dissection or stretch to cranial nerve 11 or the accessory nerve, or there is very, very quick, abrupt stress, or possibly the occlusion of a foramen, usually by a tumor. You're not necessarily going to be able to accurately or meaningfully identify a tumor, and you're not going to be the person, if you're an osteopath, well, okay, I should be careful here. In most cases, osteopathic practitioners are not necessarily going to do abrupt movements to patients in the cervical region. In some jurisdictions, they will. In some jurisdictions, they will do high velocity, low amplitude thrusting. And you could cause damage to the accessory nerve if it's abrupt enough or far enough, which is why in most cases you would actually suggest not doing those things. You would suggest not doing long or extended bouts of traction to the neck, extended bouts of stretching or tension on the neck, or abrupt movements. If you do that, you're unlikely to cause a problem with cranial nerve 11. You will not be hard-pressed to identify a palsy of cranial nerve 11 because the patient will have a bit of a problem moving the neck in some ways or shrugging the shoulders to some degree. Now, it's not perfect because the manner in which, say, the trapezius works is not perfectly with respect to shrugging the shoulders. It's part of it, but it's not entirely it. And there's discussions with respect to functional anatomy that are occurring that would suggest that this may not necessarily be an upper trap function if you look at the angle of the fascicles of your upper trapezius. So there's discussion to be had there, but you won't be terribly hard pressed to find that. But it is unlikely that you will cause this. It is likely that this will have been caused either by an accident, which would include trauma, or by a medical procedure, and it would have been identified before they even came to you. Now, in the case of a traction-based injury, if you are trying to mobilize the region, you're not necessarily going to make it better. You may actually make it worse, right? Because you're disrupting an already disrupted tissue. So you want to be careful with something like that. But if the shoulder girdle and the neck are having some problems, you might be able to, on a gross level, without the ability to name, say that there's something wrong, send that on for further diagnostics. So the pathophysiology here, pathophysiology of spinal accessory nerve injury depends on the etiology and the mechanism of injury. Axonal injury is typically followed by Wallerian degeneration, evidenced by needle electromyography and scar formation causing muscle atrophy and contractures. So you would see some kind of contracture, you would see some kind of muscle atrophy, especially bilateral. So you would see one side smaller than the other side. Rarely, the spinal accessory nerve is incidentally damaged while exploring the posterior triangle of the neck. In other cases, one of the small branches of the accessory nerve innervating the upper trapezius muscle may be damaged if it is not identified clearly during a neck dissection or surgery. So if they don't accurately identify the nerve itself, they might damage it during surgery. In nerve-sparing surgeries, the mechanism is skeletonization, traction, and devascularization of the nerve. Now, something to be aware of there is that nerves have blood supply, but it is inconsistent within the same person, so side to side. It's inconsistent between people, so it's poorly described in anatomical texts. You will have areas that have good blood supply and areas that have essentially no blood supply within a nerve. These are very small arterial supplies. They can get ripped out pretty easy, especially with traction. So just holding the neck in one position during a surgery could actually affect the blood supply of a nerve. Stretch on the accessory nerve impairs intraneural microvascular flow, causing ischemia and subsequently axonal rupture and degeneration. Usually when the stress on the accessory nerve due to traction is spread over a longer period of time, it is endured better than sudden and large stretches as encountered in sudden acceleration, deceleration injuries. So this is usually collisions. So vehicle collisions or person-to-person collisions, things like football, things like wrestling or grappling broadly. Anyways, you again get from this that you can likely identify through contracture, poor motion, or shrinking. I looked at the term just a second ago. I don't remember the damn term. What is wrong with me? Please excuse me for a moment. Nope, it's not coming to me. It's in there, but damn term. It's pissing me off now. I can find it, I swear. I'm just scanning. Anyways, that's okay. The term is not coming to my head. Atrophy, that's it, atrophy. Anyways, we're going to move on to ankylosing spondylosis or ankylosing spondylitis. So ankylosing spondylitis, cause of ankylosing spondylitis remains largely idiopathic, aka they're not 100% sure about what it is in most cases, but there seems to be a correlation between the prevalence of ankylosing spondylitis in a given population, the prevalence of human leukocyte antigen B27 in that same population. The rest of it is not necessarily useful. The pathophysiology of ankylosing spondylitis, chronic inflammatory disease with an insidious onset. Insidious is slow. Progressive musculoskeletal and often extraskeletal signs and symptoms are characteristic of the disease. The rate of progression can vary from one patient to the next. Primary pathology of spondyloarthropathies is an enthesitis with chronic inflammation. Cytokines, particularly tumor necrosis factor alpha and transforming growth factor beta, are also important in the inflammatory process, leading to inflammation, fibrosis, and ossification at sites of enthesitis. So you're not necessarily, as an osteopathic manual practitioner, going to identify the tumor necrosis factor alpha. You're not going to identify the inflammation specifically. You're not going to identify the specific joint pathologies. What you're going to identify is something, a large portion of the spine is not moving at all, right? They call it, I think, the bamboo stick spine. Very, very stiff. It just doesn't move. By the time a person presents to you as an osteopathic practitioner, you're not going to be in a position where this is the first time the person's been examined. They will have had a lot of problems for a long time. Somebody will have very likely noted to them that they have ankylosing spondylitis. So they're going to have that very, very stiff back. You know, when they go to look over the shoulder, it's going to look like the whole body rotating, and it might actually be their feet turning, not necessarily their torso, right? Everything's locked up. So you will, if this is early with respect to the patient, you might see areas where no matter what you do, nothing generates motion in the vertebral column. No change is occurring. So you would, again, note a gross change in the movement of structures without the ability to name it, and you would send on, because you're not going to find tumor necrosis factor alpha. You're not going to find transforming growth factor beta. You're not finding these things. You're finding gross identification of a change in anatomical function with minimal or no ability to name it, so you send it on. Right, then we will go and look at gotta go higher. Something like pericarditis, right? So pericarditis is inflammation of the pericardium, or the sac that the heart sits in. Etiology. I'll try to be quick here. Viruses are considered the most infective agents that lead to pericarditis. So there's specific viruses that it's going to name. We don't need to necessarily look at those. Non-infectious causes are numerous and include malignancy, often secondary or metastatic disease. So that's essentially tumors. So things getting in the way. Connective tissue disease, such as systemic lupus erythematosus, which is SLE, or most people will just say lupus, rheumatoid arthritis, and Behçet's disease, and metabolic etiologies such as uremia and myxedema. So essentially what you're looking at is stuff that will either take up space or alter the connective tissue itself. Trauma may also cause pericarditis with early onset following injury, or as more frequently encountered in clinical practice, result in delayed inflammatory reaction. Dressler syndrome, also called late post-myocardial infarction syndrome, is a well-recognized post-cardiac injury syndrome, whereas pericarditis is preceded by acute coronary syndrome with delayed inflammatory response, usually several weeks after the initial event. So viruses, trauma, connective tissue disorders. Trauma you can identify because the person tells you about the trauma. They got hit, they got cut, something happened. The connective tissue diseases, you might, let's just say it's rheumatoid arthritis, you might see the hands that are displaying signs of rheumatism or the term's escaping me again. There's too many terms I'm running through here. Essentially autoimmune condition. So rheumatoid is autoimmune, where you're attacking bony tissue more or less, and you'll see, kind of the puffy knuckles and the clawing hands. You'll see stuff like that. That doesn't mean that you're going to know it's affecting the pericardium. So you're not going to be able to identify it. You'd be able to identify something in the hands that is notable. And if the patient hasn't already had diagnosis, you send that on for further diagnosis. So again, you're able to do gross pathology without essentially gross pathology with little or no ability to name it, but you can send on for further diagnosis. So essentially, my argument would be that osteopathic hands-on practitioners are really good early warning signals that something's very wrong and that a physician should investigate more. Look at the pathophysiology of pericarditis. Pericardium serves multiple functions. It acts as an anchor to the heart within the thoracic cavity, forms barrier to extrinsic infection, enhances dynamic interaction between the cardiac chambers. Should be noted the pericardium is not necessary for human survival, as there are reported cases of congenital complete absence of the pericardium discovered incidentally in asymptomatic patients. So that's an interesting thing. If you're attempting to make claims about the organs, you should be aware that there are times when the organs are not in the place that you think they are, or they're not built the way you think they are. As is evidenced here, there are asymptomatic patients that have no pericardium. There will be some other connective tissue enveloping the heart, but it is not the pericardium, and there's no problems. And or no symptoms. So what we briefly want to do is identify the difference between a sign and a symptom. A sign is something that is quantifiable, measurable, and identifiable, especially by the practitioner. So usually a sign can be identified by the practitioner and the patient. A symptom is that which can only be identified by the patient, as it is unobjective and it is a sensation that will be reported by the patient. So if a patient is used to having no pericardium because they've never had one, there will likely be no symptoms because it feels completely normal. So on a sensory level, it's normal to them. We'll move on. Despite concerns for increased cardiac mobility and displacement within the chest cavities, studies have shown that similar left ventricular ejection fraction and life expectancy of these patients as compared to the general population. Due to the parietal layer's richer innervation, any inflammatory process mediated by an infectious, autoimmune, or traumatic insult can result in severe retrosternal chest pain, as is commonly seen in acute pericarditis. This explains why the vast majority of presentations, greater than 90%, have chest discomfort. In cases of pericardial effusion, the pericardial compliance can increase in response to slowly accumulating fluid, allowing the pericardial sac to dilate over time without compressing the cardiac chambers. This means the rate of fluid accumulation and resulting pressure changes, as in pericardial compliance, is often more important than the volume in determining the hemodynamic sequela affecting the heart. By this virtue, a relatively small pericardial effusion can cause life-threatening tamponade, which is essentially accumulation of blood around the heart itself, around the actual muscle, if it accumulates precipitously, while an incipient process, or slow, such as a malignancy, can allow a large pericardial effusion to form over weeks before exerting constrictive physiology over the cardiac chambers. So a lot of words basically to say you're going to have swelling within the pericardium itself. You'll have retrosternal chest pain, so pain behind the sternum, right? Which is where you would suspect that some of this would occur, or some of the sensation or some of the symptom to occur. If it's slow, the heart can work pretty well. So if there's a tumor growing, or if there's effusion or swelling growing in the region of the pericardium, if it's slow, the heart can continue to work pretty well. If it's fast, it's very dangerous. Either way, if the patient is reporting to an osteopathic hands-on practitioner and they're noting pain behind their sternum or chest pain generally, and they've likely tried multiple interventions. They've likely tried some form of anti-inflammatory, some form of medication, or some form of over-the-counter for heartburn. So for it's the proper term for heartburn. I'm not going to remember it right now, but they've tried something. It doesn't mean that you know that this is pericarditis or myocarditis or say pneumonia. You don't necessarily know any of those things. You just know that there's something very abnormal in the region of the thoracic cavity that you should send on. So again, the identification of gross pathology with little to no ability to name it, but the ability to understand that you should send it on. So what I'm going to do is stop the share here, because I've gone through a lot of details in a very, very small amount of named conditions. So in a very small amount of pathologies, you can see that if you look at the pathophysiology, oftentimes you will find some form of mechanical component, especially in the form of stuff that takes up space. As an osteopathic practitioner in the hands-on world, from your external environment of observation, you're very unlikely to identify specific tumors, specific, essentially space-occupying things. You will often be able to identify abnormal presentations, so what the patient tells you versus what you find. So if the patient tells you that there's a lot of chest pain and the let's just say the thoracic cage is moving well, the pectoral tissue is moving well, the shoulder girdle is moving well, the neck's moving well, everything is doing as it working and moving as it should work and move, but the patient has a lot of pain, that's a really good signal that you should send them on. So again, you can identify gross pathology. Let's just say somebody presents with retrosternal pain, so they have pain behind the sternum, and their left shoulder moves horribly and their right shoulder is fine, and their thoracic cage is not moving particularly well. You have the beginnings of reason to believe that the rationale for the sensation that they're experiencing in the form of pain could be the lack of compliance of the thoracic cage and the problem with the left shoulder. So what you would do, as long as you have reason to believe it's safe, is you would try to increase the compliance of the thoracic cage of the ribs and try to get the left shoulder moving better. If that brings about a minimization of the sensation that the patient reports, then you have good reason to believe it's not particularly dangerous. However, if it's retrosternal pain, you should still make sure, especially if it's been there for a long time, you should make sure that the patient gets checked out by a physician. They'll often say they don't want to, but you should still try to convince them that they should see their physician. If with very, very few treatments or one treatment, the thoracic cage starts moving well and the left shoulder starts moving fantastic, and there is no return of the symptom, no return of the sensation, then you have really good reason to believe that what they were feeling was because of that lack of motion. So as osteopathic hands-on practitioners, we're in a very, very rough observational position, because there's some things we can identify with patient report, some things we can identify with respect to motion assessments, so either compliance of soft tissue or yield of soft tissue to pressure or gross motion of anatomy. And we can often relate those two. When you have a report of sensation that is concerning and concomitant motion findings or motion dysfunction findings, and a reduction or absence of reported symptoms subsequent, you have good reason to believe that it was pain due to the motion problem. If you get the motion problem working better, and there is no change in reported sensation or reported symptom, then that's probably an issue that a physician needs to deal with. So as far as pathophysiology is concerned, there will be times when there's a mechanical correlate to health and disease states, or at least a mechanical correlate to reported sensation. As osteopathic hands-on practitioners, we deal with that very well. As the ability, or as far as our ability to identify pathophysiology, it's essentially non-existent. We can do a very good job identifying gross pathology with little to no ability to name things. So again, we're really good at early warning signs when the reports of the patient and the sensations do not match the physical findings. Really good reason to send them on. So retrosternal pain, everything's moving really well in the region, send them on. Retrosternal pain, obvious motion problems with the left shoulder and the compliance of the thoracic cage. Okay, maybe that's a reason worth investigating as far as driving the sensation. If there's cessation of the sensation subsequent to improvement in motion, got a really good reason to believe not that big a deal. In almost all cases of odd pain presentations, you should send it on anyways. So hopefully that gives some insight into why I argue osteopathic practitioners should not be considering pathophysiology, broadly speaking. It doesn't mean you shouldn't know it. There's a huge amount of information to go through. You're likely not going to meaningfully go through it. It's one of the reasons there's specialties in medicine, because they can choose a subset to go through and be very, very in tune with. As practitioners who would be considered very general in our approach as osteopathic hands-on practitioners, our ability to understand pathophysiology is very minimal. Cognitively, we likely are not in a position to do a good job with that. However, we can be extremely effective as early warning signs with respect to gross pathology with little to no ability to name it. So hopefully that gives you some good insight, and we'll talk to you again soon.